Broadcast is now starting. All attendees are in listen-only mode.
I'm Amy Weiser. I'm a mom. I'm a partner. I'm a family doctor is my medical training. I'm also a board certified lactation consultant. I live and work in Portland. And today I'm going to be talking about primary HPV screening, which we're going to be calling the new PAP. So this is something that is coming down the pike that will start to be integrated into cervical cancer screening. And you are going to be on the forefront of learning about this. So hopefully we'll have some good discussion at the end of the talk today. And if you have any questions, I'm more than happy to answer and go from there. So let me, okay. So the slide deck that I'm using, it was developed by the American Cancer Society National Roundtable on Cervical Cancer Primary HPV Screening Initiative, which is a lot of words, but it's something that I'm involved in. I'm on the provider work group as part of this. And really what this National Roundtable that was just launched in the fall by the Biden administration as part of Cancer Moonshot, we're really trying to close disparities related to cervical cancer across the continuum. So screening, diagnostics, treatment, and then survivorship as well. So this is kind of in its infancy as we develop the roundtable and get things going with national organizations. But I am lucky enough to be part of this. I'm also on the ASCCP board of directors. So disclosing all the stuff that I do, I don't get any money for any of this, but I'm on the board of directors, and the ASCCP is the organization that publishes the management guidelines. So if there's an abnormal PAP and HPV result, these are the folks that help to guide next steps. So, yeah, so I do a lot of stuff there, and this is one of my passion interests within medicine. So what are we going to do today? Well, we're going to talk about primary HPV screening, and we're going to do this within the context of this is the preferred screening modality per the American Cancer Society. We're going to talk about the pros and the cons of this approach, 3 options for managing abnormal screening results, and then talk about some new developments that are happening in cervical cancer screening as well as management. So I think that we should level set and kind of talk about the beginning, which is cervical cancer prevention. And how do we do this? Well, we do this through screening, through progress and elimination. So back in 1927 is when Dr. Papanicolaou first started using cervical cytology to detect cervical cancer. And I think most of us, when we think about Dr. Papanicolaou or PAPs, they really gained more popularity as a screening in the 1950s. So definitely took about 20 years for that to get going in mainstream medicine. But, you know, since the 1950s, we've seen significant improvement of the rate of cervical cancer. As you can see by the chart, which starts in the 70s, there has been significant decrease in the amount of cervical cancer cases by about 80%, which is really, really great. What Dr. Papanicolaou didn't know, and what was discovered and won a Nobel Prize in 2008, is that really the origin or the etiology of cervical cancer, so those changes, those pre-cancer changes, those cancer changes are actually from HPV, the human papillomavirus. So that truly is a causative agent for cervical cancer. And I like to think that, you know, if Dr. Papanicolaou knew about HPV and HPV screen, that would be the test that we would use to detect cervical cancer. And we'll talk about this a little bit more. I do want to point out that even though our rates have decreased significantly, they're still present. And in 2023, in a country that has plenty of resources, why is this still the case? This is a cancer that we understand the causative factors and that we can intervene with. Well, I think that one of the things that we need to think about is how do we screen for cervical cancer? i.e., you know, this is very opportunistic. You need to be in an area that has a medical provider. You need to have access to these screenings. And not everyone does. So certain subpopulations of women, as well as gender variant people with a cervix, as we need to be inclusive, are living in low resource medical underserved areas. And so disparities still exist with cervical cancer screening, much less treatment and survivorship. So just kind of think about the context in which we're going to discuss this today. Now, I said screening a lot, and I think that sometimes screening and the word surveillance can be used interchangeably. You might think, oh, it's kind of semantics, but it really isn't. It means different things. So screening is testing for disease among patients with no symptoms and all normal prior results. So this is a very low risk population, kind of that baseline that we think about. Surveillance is something that we do when people have a prior abnormal result. And so we're making sure that we're monitoring these results, that they're not worsening these abnormalities. And so these are people who we would see at shorter intervals and maybe be more attuned to any changes or worsenings that would happen. So diagnostic testing, I'm just going to throw that out there, is needed when a patient presents with a symptom, right? So screening, okay, you're due for your cervical cancer screening. Surveillance, you've had an abnormality, when we want to bring it back, make sure that we monitor this. Diagnostic testing is when someone's not due for cervical cancer screening, but they're having symptoms. So bleeding would be a symptom. So that would be diagnostic testing. So to summarize, cytology and HPV, these are screening tests. Diagnostic tests can be a colposcopy, and then treatment for abnormalities could be a LEEP or cryotherapy or cold knife cone biopsy. And this is how we approach this in the United States. Different countries do it in different ways, but this is the system that we use. So, in talking about that a little bit more, this is a graphic from WHO, World Health Organization, and WHO is really, having the charge globally to try to reduce cervical cancer incidence. Now, how are they doing this? And they have a target of 2030. We're already in 2023. So again, lots of work to be done. But, 90% of girls, and they use binary language, so girls, but really this can expand to anyone with a cervix. They want to have fully vaccinated by the age of 15 years. We know that vaccinating before sexual debut, the earlier the better. You only need 2 doses of HPV vaccination. We're really trying to increase that primary preventative approach, whereas you're trying to eliminate the HPV virus in totality, much less before it kind of sets up shop and starts changing things. And then in addition to this, 70% of women to be screened by the age of 35 and again by the age of 45. So why these ages? Well, we know that the longer that you have an HPV infection, if you were to have a high-risk HPV infection, it doesn't cause precancerous changes straight off the bat. It does take time. And so if someone in their 20s had been exposed to this by the time of 35, we would start to appreciate changes of the cervix, precancerous changes, if they were to develop. And then again at age 45. Why is it not every 5 years, or every 3 years, or something that we're more used to? Well, because resources, globally are a fair bit different than the resources that we have here. And then the third target is for 90% of women who have cervical disease to receive treatment. So precancerous, cancerous, invasive cancer to be managed. I think that these goals are amazing. I think that we have a lot of work to do on a global scale. But these are things that we can take from WHO and also apply to the environment that we're in the United States and in our cultures as well. So screening, how do we screen for cervical cancer in the US? Well, we have guidelines. Okay, this slide in the slide deck is super, super busy. It's colorful. Let's go through it together because it's a little overwhelming. Each time I see it, I'm like, whoa. So this is a compare and contrast of how we screen and who recommends these screenings for the United States. So hopefully this is familiar to some of us. So through the American College of OBs and GYN, so ACOG, as well as U.S. Preventative Task Force, their recommendations are to start screening for cervical cancer at age 21. This is probably what most of us have been doing during our careers. And then as far as how often or how to screen, well, usually between ages 21 and 65. We do cytology only, so PAP, or moving into HPV testing with our PAP or co-testing. And so between the ages of 21 to 29, cytology only every 3 years. But if you're able to co-test your patients, then between the ages of 30 and 65, that's what you tend to do. And that's on an every 5-year interval. So you can do cytology alone, you can do co-testing cytology and HPV. Or between the ages of 30 and 65, you can do HPV testing alone every 5 years. Now, any of these are acceptable. Any of these work. It's usually whatever you have available in your institution or your system. And then to stop at age 65, based on 3 consecutive negative PAPs or 2 negative co-testing. So basically, we're looking at a 10-year interval of normal, negative screening before we would cessate cervical cancer screening around the age of 65. Okay. This also has with it that you would have no prior history of a high-grade finding, a precancerous finding, or treatment in the past. So there's a little caveat there. I'm going to compare and contrast this to the American Cancer Society. Now, their recommendations are a little bit different. Their recommendation is to start screening at age 25. So 21 has now moved to age 25. And they say that, well, if you have co-testing, do co-testing. If you have cytology, do cytology or just pap smears. But ideally, and this is the preferred methodology of screening, is to use primary HPV screening, and this would be every 5 years. So a little bit different here, and we're kind of pushing ourselves into the future with the understanding of science and the causative agents that we have for cervical cancer. When to stop according to ACS guidelines? Same time, age 65. So 10-year negative screening history, as well as no history of any high-grade findings and treatment required in the past. If that is something that is in your patient's history, you would need to screen for 25 years after this, which may put people past the age of 65. Okay, so something to think about there to make sure that your surveillance of these patients are going to catch any recurrences. Okay, so you know, why the difference? Well, we're going to talk about that a little bit. We're going to talk about why primary HPV testing. There is a lot of literature, a lot of research that does support this, also supporting the age at which to start screening as well. The interesting thing is that the U.S. Preventive Task Force, Preventive Services Task Force, I always forget the service part, they are anticipating new guidelines for cervical cancer screening to be published maybe by the end of this year, probably by 2024 as things get delayed. But we shall see how maybe better aligned with a preferential screening test that they might concur with ACS. Okay, said a lot there. I realize that. Okay. So I mentioned HPV or primary HPV screening. So what is it? Well, you're testing for HPV first. That's what you're testing for, right? And then if there is any abnormality, a triage test such as cytology or HPV genotyping would be performed. So the presence of high-risk HPV type definitely indicates a risk for developing a cervical precancer or cancer, especially if you have continued detection of HPV infection over time. So currently there are only 2 HPV tests that are FDA approved for primary screening, and we'll talk about that in a second too. Okay. All right. So why are we going to do this? Why the change? You know, like I always think about, well, what is the effect of this? What is the data supporting this? Like, is somebody bored? They feel like we need new guidelines. Does somebody want to make more money? You know, these are all of these critical questions that I think we should always ask when we update our practices in medicine. And this definitely has a lot of data behind it, and really is something that globally these practices are changing too because of that.
So why do primary HPV screening? What's the deal here? Why is this better than cytology? Why is this better than co-testing? Well, it has improved sensitivity for CIN3+. So what's CIN3+? We're talking about high-grade cervical dysplasia, high-grade changes of the cervix that are seen over time that are caused by HPV. And so primary HPV testing definitely finds these with more sensitivity over cytology alone, right? Over 50% better detection rate. And so this is comparing just cytology, just your PAP alone. There's minimal loss of cytology over co-testing for CIN3+. The difference is not statistically significant. So if you're comparing co-testing, which is cervical cytology, and HPV, you know, there's minimal loss of sensitivity if you're just doing primary HPV screening, but it definitely has increased sensitivity over cytology alone. The pro is that it's much more efficient than co-testing. So we will see through this screening that there's a similar reduction in cancer, but as far as resource utilization, it's far less fewer testing that's required. There is a potential for self-sampling with primary HPV screening. It's not FDA approved yet, but hopefully it will be. And so it really opens up where the screening can happen. You know, I mentioned that there are some medically underserved area, low resource area. This is something that if we compare it to colon cancer screening, which we see commercials for, which can be delivered to your door, it's that sort of ease, availability that can hopefully be applied to cervical cancer screening in the future. And so improving access is another advantage. Moving on, disadvantages, because with pros, there's always cons. There's lack of specificity within this screening modality. It does require a shift in infrastructure to have this screening available in our institutions and systems, as well as appropriate follow-up if HPV screening is positive. One of the things that has come out of COVID is that we now do COVID testing, right? Well, there have been upgrades in lab systems to make COVID screening available. And some of these same platforms also have integrated primary HPV screening. And so there is maybe a light at the end of the tunnel. Some systems may already have this capacity. And so the infrastructure, if already there, can definitely be moved upon a little bit quicker. Like I said, only 2 tests are FDA approved for primary HPV testing. So if you're like, oh, I'm doing co-testing, no, I'm just going to change it and put the order in the lab for primary. It's not the same thing. It's not approved. We can't do it. So not all HPV tests are approved for primary HPV screening. So I talked a little bit about sensitivity as well as specificity. So an ideal screen is going to have very high sensitivity, which allows you to capture the maximum number of people who might have the disease. So high sensitivity is great. And that is one of the merits of primary HPV testing, much more so than a standard cytology or PAP test. The PAP test performs poorly as a screening test. It has high specificity, but very low sensitivity. And so it gives you a high false negative rate. We really want a low false negative rate if we're going to use a screening modality that is of the utmost utilization. Okay. So again, a little bit of a busy slide. I'm just going to fast forward. These little boxes are going to come into view. So this is, these are estimates from modeling from different studies that have been done. And really we're highlighting the fact that HPV testing, primary HPV testing, has the lowest number of tests associated. So you can see, obviously no screening is 0. But cytology and co-testing versus primary HPV testing, there's a significant amount less tests that need to be done to adequately screen. We also see that it's also associated with the lowest cancer case as well as cancer death proportion compared to other screening strategies. And so we've really taken a look lots of researchers have looked into this, making sure that it is a reliable screening mechanism, and that we are getting the results that we want, which is to work toward elimination of cervical cancer. Okay. So we know that HPV screening alone is going to predict future risk a bit better than cytology. And this is an older study that came out, I guess, about 10 years ago, which is to show us, it shows us that a persistent infection of HPV is the agent for the majority of cervical cancers because HPV persists and can drive cell proliferation in the transformation zone of the cervix, which is where we see most of the precancerous lesions. Majority of HPV infections, thankfully, spontaneously regress. But of those that progress, there is a long latency period. And that's the tricky part when it comes to HPV. It's hard to detect, hard to determine who's going to have HPV, and it's hard to determine the effects of it. So both HPV and cytology can predict risk at the time of screening. So if a person comes in, has an HPV positive, has an abnormal PAP, this is the risk that we're talking about right now, okay? And from that, we know that having a positive HPV result is more predictive than cytology when we're thinking a 5-year risk of developing precancerous high-grade lesions like CIN3 as well as cancer. We also know that there's fewer cases of CIN3 plus those high-grade changes in those who are screened with HPV-based tests versus cytology alone. This is a European study that shows screening with HPV-based tests, and it prevents statistically more precancers than just the cytology. The difference of incidence between screening of primary HPV and co-testing was minimal. We will, lean into that too. But really, HPV-based screening tells us a lot of information, and we're always thinking about risk, right? We're always thinking about risk in the current timeline, 5 years in the future, as an HPV infection persists and proliferates, disrupts DNA, and we see precancerous changes. Okay. So, considerations for primary HPV screening. What should we be thinking about? Well, we know that HPV genotypes, some are more dangerous than others. They don't all behave in the same way. So there's over 150 genotypes of HPV. Do we test for all these? No. We test for the high-risk ones, the ones that have been associated with cervical dysplasia. We know that HPV also has a caveat, I will mention, that it causes cancers of different areas of the genital tract for both those with the cervix and those with the penis. It can also contribute to the development of throat or pharyngeal cancers as well. But for this, we're talking specifically about cervical cancer, as most of the research has been done in this field. So this is a study that was published, probably over 15 years ago. And it was a 10-year collective analysis of high-risk HPV types. Suffice it to say that those are the highest risk for HPV 16 and HPV 18. These are commonly genotyped out with HPV testing that we currently have, and that as we move into the future with technology, we will continue to have. So we know that not all HPV subtypes or genotypes behave in the same way, but we're definitely more inclined to worry when you have HPV 16 or HPV 18 in your patient. So not all HPV genotypes behave the same way, but also not all HPV tests are the same. So only 2 are approved for primary HPV screening in the US, and it's the Cobas, it's made by Roche, and it's also the which I can't see on my screen, is the BD on Clarity. So these are approved, which means that if you have HC2 or Aptima in your lab, these are not going to be ones that you can switch over to primary HPV testing. Now, how is this reported? Well, it's reported in different ways. Cobas has 16 and 18 reported, and then they have a group of 12 other high-risk HPV genotypes, whereas the other primary HPV approved test will give you 16 and 18, and then it'll give you groupings of other high risk as well as individual reports. So you'll see it a little bit different. How many visits are needed for primary HPV screening? Well, these have been studied and are validated to use with thin layer cytology samples. It means that the clinician obtains these samples and if positive for primary HPV, then cytology and genotyping is going to be reflexively performed as a triage. You may also need to order reflex cytology with your lab if you are pursuing primary HPV screening to make sure that everybody is on the same page and that they are following the necessary steps for triage for your patients. I think that there's some concerns whenever we move from one screening modality to another. Remember, once upon a time, it was all about, do we do a colonoscopy versus a sigmoidoscopy, right? And so as we get more data, more studies, and more retrospective data, we kind of reconsider what we're doing and why. So I think the major question that we all want to ask is, geez, are we going to miss cancers in our patients? We don't want to switch to something that we think is going to be better. And then we're going to miss things that really is the point of the screening. So most cancers are caused by HPV. HPV has been shown to be more sensitive, detecting precancers earlier than cytology alone. And there have been different studies. So in a review of over 4 million, that's a lot, 4 million co-tests with negative HPV, the risk of an abnormal PAP, so something that is greater than low-grade findings, leading to a colposcopy and a diagnosis of invasive cancer, was about 18 per 4 million tests, okay? Over the last 17 years, Kaiser Permanente in Northern California, which has some incredible data sets and registries, this is where we get a lot of our data from, through ASCCP as well as National Cancer Institute and American Cancer Society. They estimated that one cancer would be missed per year out of a population of 3 to 4 million patients. Okay, one cancer per year, 3 to 4 million patients. So are we going to miss cancers? Probably not. Very few and far in between. And so we can kind of be reassured that switching to this modality is going to be safe for our patients. Will colposcopies increase or decrease? Well, it's a little bit unclear because we know that the younger generation is being vaccinated for HPV. So ideally, that would mean that we would have less abnormalities on PAP and co-testing and HPV screening, and so less follow-up diagnostic studies would be needed. But we still have a generation that hasn't been immunized with HPV vaccination, and we're still getting abnormal results in these patients. So I think that the answer is going to be, it might wax and wane, it might ebb and flow as far as number of people who are going to be indicated for colposcopy. Are patients going to still come and see us? Well, I hope so. I'm a family doctor. I want to see my patients and I want to see them on a regular basis. So there's still lots of reasons to come in, get checked out, preventative healthcare, annual check-ins. That is still going to remain the same. And the frequency of primary HPV testing is the same as co-testing. So as you're seeing patients come in every 5 years, this will remain the same. It's not going to extend in duration there. So, okay, well, we kind of know what we do if we have an abnormal PAP or an abnormal co-test, right? We're sort of used to the algorithms of yesteryear, and now the app through the ASCCP to help us with management, basing things on results and risk versus, basing management on risks rather than just results, a once and done. But how do we manage positive HPV test results? Well, what's management? Management guidelines refer to managing abnormal results, include guidance for ongoing surveillance after primary abnormal results are treatment. Here in, we introduced the ASCCP and what we do here. And we've taken this into account. So after a positive HPV test, there are certain things that are going to happen reflexively for triage. So there might be partial genotyping 16-18,
There might be extended genotyping performed as well. This gives us better information. A reflex cytology. So from the sample, we're going to go back and look at the cells under the microscope. Make friends with your pathologist. They're lovely, adorable people who will invite you down into their lab because they like to show off what they do. And then there's also different stainings that are coming into mainstream pathology, dual staining, P16, Ki67. Some of you may be familiar with P16. I think that's been becoming more common in the past few years. But reflex testing, I just want to say for cytology, it's best if it's from the original collection, but it may not be. Your lab may require a second collection for the cytology. So there's some nuances there to be familiar with. So management, currently we report genotypes, so HPV 16 and 18, plus some other individual and pooled genotypes, so the unclarity. We know that HPV 16 is the most carcinogenic, most dangerous. It's associated with over half of cervical cancers. HPV 18 is associated with up to 15% of cervical cancers. And so knowing this and having the studies already accounted for, the ASCCP management guidelines are already using 16 and 18 genotyping as well as pooled results. So it'll say, if you have an abnormality, you can click on 16, you can click on 18, and then it's other. And so this is where the pooled results are going to be accounted for. We know that persistent HPV is highest risk. A prior HPV test result, so that continued positivity is going to put a patient at higher risk for developing a precancerous change. And we know that individual patient risk is what we're using now to determine management. Gone are the days of saying, oh, this is the result, and this is what we need to do. We need to take a look at the current result, but we also need to think about the last result and additively consider what a patient's risk is going to be, and this will determine management. So how are we going to take this and apply it to primary HPV screening? Well, there is an algorithm. It works the same as the ASCCP management, but this is kind of a nice chart to follow along. So HPV testing, if your primary HPV test is negative, I will see you again in 5 years for this. Hopefully sooner for other things, but I will see you in 5 years for your next cervical cancer screen. If it is 16 or 18 positive, well, I'm going to look for that cytology to be done reflexively at the lab. If they can't do it, unfortunately, I'm going to invite the patient back in for another visit to collect this. And then depending on the risk, so high risk, low risk of the cytology, so high grade versus low grade interpretation, that is going to determine, well, is this person going to need a colposcopy or are they going to need diagnostic treatment? Okay. If 16 and 18 are negative, but some of the other high risk HPV types are positive, again, we're going to go ahead and do our reflex cytology. And again, determine, or based upon, if it's normal, we'll see them again in a year. Not too uncommon from what we're doing already. And if there is an abnormality on the cytology, then we'll go ahead for colposcopy. So this algorithm is for screening. It's not for surveillance. If you have someone who has already had an abnormal history, you would be approaching it a little bit differently. All these are shared decision-making. And as we expand the genotype testing, the algorithm will also be expanded. But for right now, it's just 16 and 18 and other pooled. Okay. So I'm talking a little bit about the US. What's everybody else doing? What's everybody else doing in the medical community? Well, multiple studies have been performed in different countries that also support effectiveness of primary HPV screening for cervical cancer screening. So the Netherlands, Sweden, Australia has a lot of studies. The Athena study here in the United States as well. And really they're saying that there is high efficacy of this screen with really good supportive data to invoke this as a preferred screening methodology. There are some countries that recommend primary HPV screening. So you can see, let's see, So the ones that are solid colored, such as Australia, primary HPV screening is really what the recommended modality is. There are some others that, like the United States, where you can do cytology, co-testing, or primary HPV screening. There are other countries that are not quite there yet. So a lot of countries in West Africa where they're doing a visualization using acetic acid applications. So they don't have cytology. These are countries that the UN as well as WHO are really targeting to try to start primary HPV screening for self-collection, for lack of need of cytology. A lot of people don't have pathologists in the country, or very many. And so thinking about resources, HPV primary screening can really capture a medically underserved area. New developments coming toward us, additional high-risk types are going to be identified. Some of these, as we get better data, how dangerous, how carcinogenic are they? Some of these may require immediate colposcopy, depending on those results. Those who are deemed to be at lower risk, if we know specifically what they are, such as 59, 56, and 66, these would be patients who may not need to go straight to colposcopy if they have higher risk findings on the reflex cytology, but rather can be surveilled and come back in a year for further testing. So really, this is allowing more precise identification, type specific persistence, and we're taking this risk and we're correlating it to the surveillance and the treatment and management that we need to do to keep our patients healthy. P16, Ki67 dual screen. I think that this is very pretty and very cool because I'm a huge dork about this kind of stuff. But if you have P16 positivity and Ki67 positivity, it means that there's probably going to be a fairly good chance that there's some high-grade changes going on. So Ki67, it's a marker of cell proliferation. Okay. P16, it's a marker of loss of cell cycle regulation, right? This is the hallmark that if you have P16, it means that things have gotten a little funky, that HPV has incorporated itself into cell proliferation, and there have been some mutations and some changes, right? So it increases the risk for dysplasia or cervical cell abnormality. If you have P16 and Ki67 in the same sample, that is really not great. They shouldn't be in the same sample. So if you're looking under the slide or under the microscope where your pathologist is, and you're seeing both P16 and Ki67, my response would be, no. That should not show expression in the same cell. And so as our staining get better, as our understanding of cervical cancer origin, progression, development get better, these are stains that we're using in the lab. We're really making a huge amount of gain from the 1950s when we just did the PAP smear. We're learning so much more. I think Dr. Papanicolaou would be pretty impressed with where his research has gotten us in the care we're giving the patients these days. So, advantages of triaging with partial genotyping and with dual stain. Hopefully we're really trying to sort out who's at highest risk, who's going to need a colposcopy as follow-up, versus who can see back in a year. Nobody likes colposcopy. It's very anxiety producing. There's a lot that plays into it. So saying, come back and see me in a year, I think is a lot easier to swallow. And if we can avoid doing excessive procedures on patients, it's probably the better. Self-sampling, I did mention self-sampling, and I do want to end with some of this. It's not yet approved in the United States. The FDA is considering it. It's in trials. But multiple studies have shown that patients really accept this way of sampling. It's effective, it's cost-effective, especially for those who are medically underserved. The sensitivity, if you take into account the patient self-sampling versus a clinician self-sampling, the sensitivity is very comparable. And so this is something that really bodes well for allowing for self-sampling. Again, same as what we would do for colon cancer self-sampling. With fecal studies. For now, a positive test in the self-sampling
population would require a physician or a clinician collected sample for triage. Studies have shown, again, that sampling by a patient versus a clinician, that really the results are pretty similar. These studies have been done in the Netherlands and other countries as well for a fair number of people, so about 200,000 for a randomized paired screen positive trial. So things that I hope to have left you with today is that, understanding cervical cancer elimination, it does require vaccination, which we didn't really talk about today, but I'm always happy to have a conversation about that. It requires a screening as well as management of abnormal results. The primary HPV screening is the most efficient screening test, and this is where we'll be moving toward in the future. And that to recognize HPV screening with triage cytology has similar outcomes to co-testing, but does require fewer tests. Quite cost effective. So hopefully I've given you some information to think about today. I would suggest discussing with your practice partners, with your institution, with your system, to see if, is this feasible? When is this going to be feasible? Again, when the changes from COVID testing, you may have the infrastructure already in place. So thank you so much for paying attention, for spending your time with me today. And if you have any questions, I'm happy to discuss.
All right, wonderful. Thank you so much, Dr. Weiser. All right, I am going to make sure that I bring back my screen here. I know that we had a couple people that came in and we actually started broadcasting our webinar right as Dr. Weiser was starting. So I just wanted to go back for a second and remind everyone here that Dr. Weiser and the planners of this activity have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And then we are going to move on here. I'm going to pull up the questions. I know we had a little bit of audio just right in the beginning, but it seemed that it kind of worked itself out. Does anybody have any questions that they want to enter into the control panel here? Looks like we have one so far.
Okay.
Let me see. I have read some articles about patients self-testing for HPV. This was in Australia, where transport and physical distance in the rural areas is a huge issue. In the US, we do not have many people who never get PAPs because they are embarrassed or it is just not culturally acceptable. Some immigrants or religious groups. Maybe this is naive, but it seems better not to need to do a public exam to screen women.
Yeah, you included a lot in that, so I want to parcel it as best I can. Yeah, there are studies coming out of Australia, studies from the Netherlands, really, talking about experience from patient perspective, from provider, from public health perspective as well. I do want to point out that there are a lot of areas in this country that are rural, that have lack of medical access, sometimes even in urban areas as well. So while Australia does have a fair distance between cities or towns or medical access points, we do as well. And so hopefully some of the lessons learned from these other countries will be able to take into account and streamline our system a little bit better. So kind of the lessons learned. Primary HPV screening, if you can self-sample, this is huge for those who culturally, religiously, trauma, psychological, physical trauma, who having a speculum exam is a very difficult ask and a very difficult challenge. And so absolutely, hopefully this will be able to capture some of those populations that have really not been inclined to come in for these exams because of the invasiveness, to be able to capture, to make sure that they are also having cervical screening done, and that if they are at higher risk, then to be able to have a shared decision-making conversation talking about, why we would need to do surveillance, why we would need to do a diagnostic procedure, and kind of weigh the pros and cons, as well as how that would be approached. So absolutely, yeah, good points.
Same Lynn Benson also said like the Indian reservations in South Dakota.
Yeah, there's a lot of underserved areas in this country, unfortunately. And so this is something that could definitely be much more far-reaching. Hopefully the FDA will get on board with this, and allow our country to move forward with inclusion. Yeah.
Does anybody have any more questions that they want to put into the question control panel for Dr. Weiser? Not that I see coming through right at the moment. So just as a quick ending here, make sure that you please complete the survey at the end of the webinar. This is going to be in the eads.com website. If you do request the slides, we'll make sure that we get those out to you by the end of the week. The recording will be available. Usually I have that done by the end of the day today. Again, if you have any questions that you would like forwarded on to Dr. Weiser, please email them to myself. I'll make sure that she does receive those. My email address is listed here at the jmontgomery@semhealth.org. Also make sure that you do go in and claim your CME and CEU certificates for completion. And then I'm going to put the activity code up here again for everyone. Again, the activity code is 73 RIPS at the eads.com website. Again, that expires. If you didn't hear that from the beginning, that activity code will expire within 7 days. So please make sure that you do go in and obtain your certificate as soon as possible is usually what we recommend, just so that way you don't forget. All right, so that would be the end of our webinar. We thank you so much for coming. Really appreciate everybody that was able to attend today. And you're available to go ahead and log out. We hope you have a great day.
Thanks, everybody.